I'm Dr. David Lankford, one of the pediatric intensivists at Lutheran Children's Hospital, doing a lecture on ventilators and respiratory distress in pediatric populations. So the biggest thing for pediatrics versus adults is that the physiology is a little bit different. When you get an older kid, like a teenager, some of the bigger football player types, the 6'2", 250 linebacker kids, they're going to act like adults. So you're going to do adult vent settings and adult management, adult doses of medications. When you get into the more pediatric side, the babies and the toddlers, the biggest difference is the chest wall compliance is different. They don't have the musculature in the chest that a big adult would have. So you're going to have to use lower tidal volumes and lower pressures because it doesn't take as much to expand the chest. The medications are all dose dependent based on weight, which everybody knows. But the biggest thing is the chest wall compliance is different. So you got to watch to make sure you're not over expanding because it can happen very easily in the smaller babies and the children. I would say the two biggest things you see in pediatrics as compared to adults is adults have a lot of COPD. They have the chronic lung issues from smoking for 30, 40 years, whereas the pediatric population are going to be more acute. They're either acute asthma, which is more an obstructive, they can't get the air out, so they're going to be air trapping, high CO2s, big lung volumes, which eventually can start pushing on things like the heart, meaning their blood pressures are going to be lower. And then the acute illness, so an RSV baby, which is not as much obstructive, but more they're kind of building up mucus and inflammation in their airways, so it's going to be more of an oxygenation issue as opposed to a CO2 issue like the asthmatics. So end-tidal CO2, the question I always ask my nurses is we'll get a blood gas, and the blood gas will say the CO2 is 90, and the end-tidal is only reading 60. You say, okay, which one is right? And the answer is both of them, but they're measuring different things. So you have to know that if you have an end-tidal CO2, it only measures the CO2 coming out. So if you have a blood gas that shows the CO2 is higher than your end-tidal, the reason for that is that the lung isn't getting the CO2 across the barrier. Whether there's fluid there or mucus there from an RSV, or there's air trapping, so the pressure is too high and you're not getting the CO2 out. There's something that's causing the CO2 in the blood to not be able to get out of the lung. So if you have an end-tidal that's reading 60 and your gas is 60, that's good. That means your lung is ventilating appropriately. If your gas is higher than your end-tidal CO2, know that both of those things are correct and they're both telling you something, but they're telling you different things. So it's not that I mean, everyone always says the CO2 is 60, the gas is 90. Well, the end-tidal CO2 is probably broke or it's not reading right. The answer is it's probably reading correctly. It's just reading different things. So it's something helpful to have. It's something you could definitely trend. So if I have a patient with a blood gas that shows end-tidal CO2 70 and the gas is reading 90, that gap of 20, I usually tend to assume it's going to stay the same. So if your end-tidal is coming down and your end-tidal is now 50 instead of 70, I would assume my gas is probably down from 90 to 72. I don't need gases over and over again. It gives you a nice gauge of where the patient is trending. So it's very helpful to have. You just have to know exactly what it's reading.
And
In the peds world, we use a lot of volume control. Pressures in the adult side are much more frequently used, but in the adults, they have that rigid chest wall and all the musculature you're fighting against. Whereas the kids, because they're so compliant, the pressures you use are going to be changing so often. It's easier to use a set volume. So a volume control, like a PRVC or SIMV, that's going to adapt to their changing wall compliance while giving them a set volume is good. We usually shoot for pressures. The literature shows like 4 to 6 per kilo, 4 to 6 mLs per kilo. You can go as high as 8 or 9. Once you start getting above 9, 10 mLs per kilo, you run the risk of like a pneumothorax or having too big of a volume for the chest. I know in adults sometimes they go up higher than that, but in kids we usually shoot 4 to 6 per kilo is kind of the sweet spot that we want to shoot for.
so how important is your I time versus your E time in ventilating these kids?
So the I to E ratio is important in kids. Once again, it all comes back to the chest wall compliance. In an adult, they have all the muscle to get the air back out, whereas a kid, you run the risk if you don't give them time to exhale. If you have too high of an I time, so you're not giving them time to exhale, you're going to run the risk of air trapping. So you got to really watch your I to E ratios. I times, I would say 0.3 to zero point 0.4 are probably as low as I would go, with a zero point 0.5 to zero point 0.6 being ideal.
Okay. What about this child that is air trapping? What are we going to be looking for with with that increased and
So you're gonna on the lab values or your monitor, you're gonna see an increased CO2. If you have an X-ray, it'll show a big expansive X-ray. But if you listen, if you just take your stethoscope and listen, you can hear whether or not they're completing an exhalation. So if you have an asthmatic that's air trapping, for example, they're gonna take a deep breath in, and they're gonna have a prolonged expiration as they wheeze, and you can hear the wheeze go ooh. And if you don't hear that wheeze stop, that means they're not done exhaling. So even if you're at a low rate, if they're not done exhaling, they're going to be air trapping. So I think the easiest thing to do is look for your CO2. If it starts to rise, they're probably air trapping, and then just listen, and you can hear when they stop exhaling. And if it stops before the next breath kicks in, or before they take another breath in, you know they're getting the air out. If you still hear that exhaling as the next breath kicks in, they're probably going to be at risk for air trapping. If you look at your plateau pressures, you can see on the vent, you can see if it's going to plateau. If you do a plateau, you can see exactly where your plateau pressure is going to be, and then you can kind of alter your vent to kind of adjust based on where the plateau pressure is. And if you have high plateau pressures, you know that the pressure inside is higher, and you're going to have to change your vent settings to kind of accommodate that. If your plateau pressure is lower, then you have a little bit more room to kind of adjust.
so what do you think?
Usually we say a peak pressure, to me, a peak pressure above 40 is concerning. A plateau pressure above 27 is concerning. If you get up into 30, um, you're kind of trending the wrong direction. Now there are kids that have chronic lung issues, your chronic trach vent kids that are chronic CO2 retainers, that they might live at a plateau pressure of 27, 30. A normal healthy kid or an asthmatic or an RSV kid, once you start getting up in there, you're gonna
Let's talk more on the pressure side of things. And
Sure.
what are your concerns with that during transport?
So pressure modes definitely have their place. They're very helpful in kids that you're not going to be able to get the tidal volume you want. A kid with pneumonia, a kid with really bad pulmonary edema, they're going to need the pressure because the volume is not going to be accurate. If you have a kid, the other is if you have a kid with a big leak. So if you have an ET tube in that's uncuffed and you have a big leak, if you give that volume, they have a lot of stuff in their lungs, a lot of pressure in the lungs, you're going to lose a lot of that volume out of the leak. So the vent will say we're giving a tidal volume of 6 per kilo, but the kid might not actually be seeing that much volume. So pressure control in those kind of mode, in that kind of situation, is fantastic. The problem with pressure mode comes in where you're not able to control your volume as much, so you really have to be watching what kind of volume you're giving. So if I say we want to give a pressure of say 18, pressure control 18 or 20 or 24, the vent is going to give it. The vent just does what you tell it to do. It's a simple computer. So if you tell it to do that and the situation has abruptly changed, the patient popped a pneumothorax or they've got a worsening effusion, the vent doesn't know. So it's going to give that pressure, whatever pressure you set. So if you have a pneumothorax and it gives a pressure of 18, there's a big space there that is going to be filled. So the vent is going to give a huge amount of air to reach the pressure that you sent. On the other side of things, if you have a developing, say, a pleural effusion or a tamponade physiology pericardial effusion, the vent is going to give that pressure, but because the intrathoracic pressure is higher, the amount of pressure it gives is only going to give a little bit of volume. So the problem with pressure control is you have an inconsistent volume based on the changing clinical picture. If you have a stable clinical picture, your kid is always going to have a leak because they have an uncuffed tube. If you have a pretty stable pneumonia, you have a pretty stable RSV, pressure control works well. But if in a changing environment or a changing pathology, we tend to prefer a volume control just because it gives us more control over the volume that's going in.
Cool. So let's
PEEP is one of the few things that really doesn't change very much from the little tiny babies up to the bigger kids. A PEEP of 5 is usually kind of the baseline in a tiny baby with RSV, all the way up to a 17-year-old with pneumonia. How high you go on the PEEP changes. So bigger kid, you can go higher on the PEEP. You go PEEPs of 10, 12, 14, whereas a PEEP of 14 in a baby, not going to do very well. But I would say people usually start at PEEP of 5 and work your way up. If you're having trouble oxygenating, you go up to a PEEP of 7, 8, 9, 10. I think that's perfectly reasonable. I mean, PEEP and oxygen are for your oxygenation, whereas volume/pressure and your rate are for your CO2. So if you're having trouble oxygenating, I would say kind of alternate. So you go up from a PEEP of 5 to a PEEP of 6, and then go up on your oxygen from say 40 to 50. And then if you're still having problems, then go from 6 to 7 and kind of go back and forth. Now, obviously, if you're at 100% and your PEEP is at 5 and you want to go from 5 to 7 or 8 because your SATs are 80, that's more than reasonable. I mean, it's a clinical indication that you need way more PEEP than you're getting. But usually I go up 5 to 6, 6 to 7, 7 to 8. When you get up in the 8 to 9, 9 to 10 range, you're still having trouble oxygenating, then you might have other things that are going on. That's kind of the 10 is kind of the cutoff where I say, okay, what else could be going on? What else is the problem here? The lung, in terms of organ systems, the lung is an easy one. It does two things: it oxygenates and it ventilates. You don't have to worry about really anything else. Those are the only two things that it does. It doesn't take away toxins like the liver or do all the crazy stuff that the brain does. It just oxygenates and ventilates. So when you have a patient that's either having a problem with one or the other, you only need to kind of worry about that until you get both. But we'll talk about that in a second. So you have an intubated patient, and there's four things you can set. You can set the oxygen, you can set the rate, you can set the volume or pressure, and you can set the PEEP. And two of those are for ventilation and two are for oxygenation. So the oxygen is obviously for oxygenation, and then your PEEP is for oxygenation. And then your rate and your pressure slash volume, depending on what mode you're in, are for ventilation. So when you have a patient that's having a problem with one, you kind of can know which one you have to adjust to fix that problem. Now, if you get a really complex lung physiology with a pneumonia or an RSV or an asthma who also has pneumonia, it kind of muddies the picture. But the basics are those two systems are easily adjustable on your vent based on which you have the problem with and which setting you need to adjust. For a patient with like a 9 or 10-year-old patient with status asthmaticus, you usually would show up and they'll have given their 3 Duanebs and they've given the steroids. And the question is, okay, what's next? Because that didn't work. And the answer is kind of not multifactorial. It's complicated, but it's can be broken down into a couple different things. One, continue giving albuterol. So continuous albuterol in those patients is going to help. It's easy to do. Even if you have to just keep giving treatments back to back to back, instead of setting up the pump with the continuous like we do inpatient, that's more than reasonable. The other meds you can give is magnesium bolus. You have to watch out for a little bit of hypotension, but you can give a mag sulfate bolus is helpful. A lot of the other stuff that we'll do inpatient, you're not going to do like a terbutaline or an aminophylline. But the biggest thing is to watch to make sure that the patient's mental status is okay. The kind of first sign you'll see that they're falling apart is they're going to get confused, they're going to get combative, they're not going to want to wear the high flow, they're not going to want the treatments, and a lot of parents will get upset because they think their 9 or 10-year-old is upset because you're doing things to them, which is part of the problem, but also it's because their CO2 is rising, so they get combative and angry. And if you get to that point, then you know you're going the wrong direction. And you want to try more invasive things such as a high flow nasal cannula or a BiPAP or something along that lines.
So
Intubated asthmatics are difficult, mostly because of similar things we've talked about before. It's a very, very acutely changing process. So as the steroids start to work, your lungs start to relax, your volumes and your pressures are going to change. Your resistance is going to change. As the albuterol starts to work, it's going to open up the lungs and your volumes and your resistance are going to change. So you have a patient that you're giving, say you're giving a pressure control of 16 to, where you're getting tidal volumes of 4 per kilo. As the albuterol works and opens things up and the steroids start to work and the mag works, and if you give epi, the epi works, all of a sudden that pressure of 16 only gives you a volume of 3 per kilo and then 2 per kilo because there's more lung to ventilate now with that same pressure. So you're going to have to be either changing your pressures or you're going to have to be giving a set volume. The problem with a volume in an asthmatic is if I give a volume of 4 per kilo, if the lungs aren't open, I'm giving that volume in a very tight, closed space. So you're giving a lot of volume to the upper airways that's not reaching the lower airways. So it's a very high pressure system. So intubated asthmatics are probably the most challenging intubated kids that we have. And it's something that you just have to basically continually change which for me is easy because I can sit in the room. But for you guys, as you're trying to do 9 other things and transport, it's very, very difficult. So.
So I would be. Say the rest about that.
So one thing I would also like to talk about briefly is patient kind of packaging and getting patients ready for transport. I would think that when you're moving a patient, it's a tenuous situation, especially an intubated patient who's on drips and monitors, and there's always a time where you're kind of transitioning from one to the other, and it's stressful for everybody. So I would say that ideally, what we would do is get everything um, on the patient from the transport side. So switch to the transport monitor, switch to the transport pumps and IVs, and switch to the transport vent before we move the patient out of the hospital bed. And then everyone takes a breath and says, okay, is the patient okay to be moved from one bed to the transport bed? And once we see that the patient is stable to be moved, then we can physically move the patient, knowing that they've already proven they're going to be stable on all the transport stuff before they move over to that bed. Thing is okay, you have an intubated patient. Now, what do you do in terms of how to keep them sedated for the transport? Once again, it's dependent on the patient. So once again, hypotension, you're going to want to avoid a benzodiazepine, so a Versed drip. My personal thought is usually as long as you don't have bradycardia, you can't go wrong with dexmedetomidine if that's an option. Starting dose is zero point 0.3 per kilo. You can go up to 1, usually a pretty good medicine for keeping a patient sedated, especially the babies. So the little tiny babies, anyone under the age of 1 is fantastic. Um, the other thing you could start is a Versed drip if you have the blood pressure for it, or a fentanyl drip if you don't have any concerns about the perfusion and the heart itself. Um, a paralytic drip is a little more dicey. There are times when you need it, but it's hard because it takes away your neurologic exam. You don't have the patient responding. You're not going to know if they're doing anything underneath there or they're awake. Ketamine is a double-edged, very sharp sword. It is very effective as long as you get the effect that you want. So it's a dissociative, makes patients confused. As long as you get enough sedation to go with it, so you can give a little bit of morphine or a little Versed to go with it to avoid the kind of the word I would use is kind of craziness. It's a real thing, and it's a real nasty thing, especially if you're trapped in an ambulance with a big sized teenager who's already doing crazy things. That's not a position I'd want to be in. So ketamine is effective, but you have to be aware that it has a strong dissociative effect, and if the patient is not sedated a little bit extra on top of it with a little bit of Versed, a little bit of morphine, something like that, you run the risk of having them have kind of an adverse reaction, and now you're fighting basically a psychotic patient, which is always trouble.
So
So intubating in pediatrics is can be easier than adults because sometimes the body habitus doesn't get in your way, but it also can be more difficult depending on the patient. So one thing, first off, the younger the patient, the more anterior the airway. So if you have a really tiny baby, you get to a house and it's a 4-day old or a 1 month old. When you go to intubate, you need to know the airway is going to be much more anterior than you would. You're not going to just kind of look and see it. You're going to have to kind of either tilt a little bit or pull really up on the neck, and then even a little bit of crike pressure to push it down to actually see the airway. So that's generally the rule of thumb: is the younger they are, the more anterior the airway is. The other thing is, in terms of tubes, if you can get a cuff tube in, that would be ideal. In the adults, they don't have as much. Um, they have airway edema, but it's less prevalent because if you think about the physiology of it, the airway in adults starts big. So if you get half of the swelling, it only goes down there. So you're still at a pretty big airway. If you start really small and then swell halfway, you almost close it off. So an adult, you can get away with an uncuffed tube a little more because the swelling's not going to be as big of a factor. And in a baby, if you put in an uncuffed tube and it's tight going in and then the swelling goes down, all of a sudden you have a huge leak. So it's nice to have a cuff tube to be able to compensate for that leak if you have to keep a patient intubated and the swelling has gone down. A lot of ERs will try and intubate babies without sedation. I'd recommend against it. You run the risk of having the baby having a vagal response as they bear down and fight you and getting bradycardic and arresting. Um, the other thing that ERs do a lot to combat that is give atropines, which atropine is a fine medicine, but the only thing it does is increase the rate. It doesn't increase your blood pressure like an epi does. It doesn't increase your perfusion. All it does is increase the rate of the heart. So if you have a pure bradycardia, let's say you have a dexmedetomidine kid and they're getting bradycardic, and atropine is going to bring that heart rate back up. But you have to know it's not actually helping the squeeze. It's not an inotrope. So if you have a baby that's bradycardic and having hypotension, I would recommend giving epi instead of the atropine if you have it available. So, to talk about briefly about the multi-system inflammatory disease and the COVID crisis that's going on, you're going to see a lot of patients who, for the most part, probably haven't been diagnosed fully. They might have a rapid test that's back for COVID, but you're going to see patients that are in multi-system organ failure with a COVID being potential. And I would say the safest thing to do is treat them like they have COVID, just because the management is a little bit different. So the multi-system organ failure in COVID will not respond as much to fluids. So you'll give your couple fluid boluses and the pressure's not going to get that much better. So I would be a little bit quicker to start your pressors. So to start a dopamine drip or epinephrine drip, whichever you have. If you have Levophed is fine as well. Just something to get the blood pressure up because they're not going to be as fluid responsive as a normal, just a septic kid or like a bacterial sepsis or pneumonia sepsis or anything like that. They're going to be in true full organ failure. The other thing is you don't want to go too far on your fluids because if their kidneys fail, they're going to be volume overload and you're going to run the risk of flood in your lungs. So I would say if the ER is given their 20 per kilo bolus or their 1 liter bolus, however big the kid is, you'd give a second one. If the second one's not helping your pressures, I would just jump right to pressors. And knowing that this is a possibility that's not going to be a fluid responsive shock because it's a true cardiogenic shock and the heart needs help to start pumping blood to get those blood pressures up.
With everything we've talked about,
mm-hmm.
What's your take home? If you could say anything.
If I give you one piece of advice or one piece of wisdom, I'll give you two because the first one's kind of a cop out. The first one is we are always here to call. Don't ever feel like you're interrupting us, that you don't want to bother us, that it's the middle of the night and we're sleeping. We're probably not. But you always have somebody to call if you ever run into problems. If you don't feel comfortable, even if you just want to double check a dose, you are in a very stressful situation with limited resources in transit at however many miles an hour, and I'm sitting at a computer. So anything, if you want me to look up a dose, just feel free to call. That's not a problem. That being said, the biggest thing that will help you is the patient. The patient will give you all the information you need. You just have to know how to look for it. So like the 9 or 10-year-old status asthmatic, is he getting combative because he doesn't want to wear BiPAP? BiPAP's uncomfortable, but at the same time, BiPAP is going to help him breathe. So he should be better on the BiPAP, more comfortable breathing. If he's still fighting the BiPAP, you probably are looking at a CO2 problem in a kid that's crashing. If you have a low blood pressure that's just not responding to fluids, it might be a fluid unresponsive shock. So don't be afraid to start an epi or give a dose of epi to get your pressure up.